Now we want to talk about validity and how it's established. So the different ways that a scale gains meaning is when we look at content, and we talked about that on the last um, video, okay, which is basically just assessing the items and the constructs that are being assessed. The second is the other two are criterion and construct, and then finally we try to get to the level of interpretation. So first we just kind of have to note the relationship between validity and reliability. And so note in this example here we have two targets, and if we are very consistent in hitting a place on the target, that's reliability, and that can be in any place on the target. We can be very distant from the bullseye and off the and be reliable. But essentially, validity is about how close are the questions or the scores reflective of the correct or target that actually reflects the attributes that we're interested in: fear, balance, function, disability, these kinds of things. So concurrent validity is where you have two scales and then you see how they agree. And we use it because one of the scales, the assumption here is that one of the scales is the gold standard, or more commonly the currently used scale for that particular construct. So if we look at, and then what you're trying to do is see if the new scale measures a similar attribute as the old scale. So if they measure similar things, then they should be highly correlated. If you get a 10 on one, you should get a 10 or corresponding value on the other. So a good example would be the Harris-Hip score and the LEM, or the lower extremity measure that we saw before. The LEM was new, the Harris-Hip score was old, so it was considered the gold standard, and essentially they tried to see if they were correlated. In this case, they were very correlated, but in essence there was greater change measured in the LEM, so then it would become, in a way, it potentially could replace the old gold standard of the Harris-Hip score and become the new gold standard. Okay, so basically you'll see these measurement studies in the PT journal, which is comparing 2 or 3 different tests that have similar constructs and seeing if they're related. Okay, and so this is a very classic example where you're looking at two instruments that measure the same thing, and the key here, it's criterion related validity, so you even expect the units of both scales to be in the same. So essentially here you have the CROM, which is a range of motion device you can put around somebody's head, and then use these compasses here to measure, rotation left and right, side bending here, and then flexion extension. And they compared the CROM, cervical range of motion device, to the gold standard of X-rays to see if they had the same reliability, or they agreed with each other. And in fact, they did. So what you'll find is in these results, you'll find R values and R square values, where an R value that's closer to 1 suggests good correlation and then suggests high validity of the new instrument, in this case the CROM. And then you can also look at the slope, and a slope of 1 means there's agreement. So here's the results from the CROM as it relates to radiographs. So we have radiographs here on the X, on the Y. We have the CROM on the X, and we can see that the values are nearly perfect. And so the CROM was in high agreement with the X-rays, and so we can note that gives us a very good, it's a valid measure of cervical movement. Okay, so the other types of validity has to do with face validity, criterion validity, concurrent validity. And so what we were just talking about is a form of concurrent validity that we call criterion, where there's an assumption of a gold standard in the two tests that are being measured at the same time. But sometimes it's either vague or it's not clear that that assumption is valid. And so we can use these other kind of concepts to kind of assess validity in that case. So known groups, convergence, and divergence. Face validity has to do with like content validity that we talked about before, which is just that the instrument appears to be measuring what it's supposed to be. And then the example here is they tested that in this study for the LEM by they asked subjects that thought that the question should have, some of the questions on the questionnaire should be deleted, so they went ahead and deleted those in developing them. And then they also had some other suggestions, like I think they asked them to remove, there was one question about sexual activity and positioning, and they thought that was too personal, so they asked them to remove that. So those changes were made to the questionnaire based on that feedback from subjects, and so that has to do with kind of the face validity of the test. And then content validity is also has to do with floor and ceiling effects, panels of experts that decide the questions are appropriate. And then there's some other statistical methods that we're not going to cover, but one of them is called factor analysis in Cornbach alpha, where you can actually test whether the questions converge on a single concept or idea. And if sometimes you can subtract a question or add a question to see if it improves the statistical value of those items converging on one attribute like fear or function or disability or those kinds of things. So as in essence, when we looked at that previous study that we've been talking about, the lower extremity measure versus the Harris-Hip scale, they both were converged, they had like a factor analysis or Cornbach alpha that suggested that they were converging on one concept, but in essence, the lower extremity measure, which was much better in terms of its psychometric properties. And we've already talked a little bit about the SF-36 having a floor and ceiling effect. And so what you'll find is discussions of content and face validity that look something like this. So we talked already about the idea of participating in sexual activity that had to do with face validity. Here's the content validity of the expert panels mentioned up here, and then the content where each item is being assessed. We can see stairs and downstairs. For each single question, there's some determination of its relevance. Okay, so once all that's done, then we still have this idea of whether the instrument has succeeded in capturing the construct of whatever the scale's trying to identify. So we saw in the SF-36, the construct is the person's health. In the the lefts, or the lower extremity functional scale, it's their lower limb problem. And so what we need to do then is to look for data that demonstrates convergence on health, lower limb, and then divergence on other things like mental ability or just personality traits or something like that, something that would be distinct or contrasting with the concept of health or lower limb problem. So let's try to give some examples then. Convergence, so the basic question is, does the gold standard apply to the measure directly? Are there concepts of the measure or constructs? So then we have our three concepts. And I think I'm going backward. So convergence is the idea that the new test should show similar results as the previous test that is meant to measure the same attribute. Because they measure the same thing, the researchers are looking for a positive correlation usually. Okay, so here's an example where they looked at the LEM and they correlated it to the SF-36. So the LEM has a slightly different construct in that it's trying to measure physical function, unrelated to health, but the SF-36 is also measuring physical function specific to health. So what's interesting, we would expect them to converge because their constructs are similar enough and the scales are the items are very similar that they should correlate. And in fact, they do. So that supports the idea that the LEM is capturing a similar but not exactly the same construct. If it was the same, this would equal 1, right? And so that's an example of convergence. Okay, discriminant or divergence is when a questionnaire is believed to be unrelated to a construct, and this also can be tested. And so the SF-36 again is a good example because it has many subscales. So it has a physical function subscale, but it also has a mental health subscale and pain subscale. And so what we can notice is that the LEM, if it's only capturing function and not other constructs, it shouldn't be related to mental health. And it certainly may be related to pain, or here it says role functional. Those are they have some kind of function, may creep into those measurements, and pain may influence function, but the way the questions are worded, it also may not, right? And so what we can see here is that the SF-36 pain scale, mental health scale, and their role function emotional, here's their correlations, which are all very, very low. So the closer to zero means they're less important, right? And there's no connection. And so this supports the idea that the LEM independently identifies function, and if you want to measure pain, also in a hip fracture patient, you should use a different scale because it's not being reflected in their answers on the LEM. And then the final example is known groups, and this is where you just see if the scale picks up differences between groups that are discriminated clinically that make sense to you. So for example, young hip fracture patients versus old hip fracture patients, or hip fracture patients that had low functionality prior to hip fracture, and those that don't, or hip fracture patients that have use assist devices versus those that don't. We would expect the LEM to pick up differences in those groups of patients. And so we could see here, those are known groups, and so all the test hypotheses are supported. So patients who had at least one comorbidity had a lower mean prefracture LEM score than those with no comorbidity. So it's fairly small, but there was a difference. And patients who had walked without aids prior to the fractures scored higher than those who had used a cane. So this is an example of trying to use known groups to say, hey, the LEM's picking up these differences in patients that we know are functioning different in relative to their self-report of function. So what did you really gain by looking at this? Well, if you pick up an article in the Physical Therapy Journal that's about an instrument and about validity, and you choose to read it, this is the kind of thing that you're going to be getting. Comparisons between two scales, discussions of convergence, divergence, and known groups. So what we would really like is for that to be translated for us into actual cutoff scores that we can use for interpretation. And so this is a good example for the tug, where basically a score of less than 10 seconds on the tug means someone's freely mobile. 10 to 19 seconds means they can carry out basic transfers independently, can climb stairs and go outside alone. A 20 to 29 score, it means they can use a cane and with some difficulty on stairs. And greater than 30 means essentially they're going to have a lot more difficulty with functional tasks. And so the value of this is very powerful. We can do, the tug test takes very little time. We can substitute this test for, say, stair climbing, our judgments based on whether they're independent outside, rather than feel like we have to test all of those things to know how they would perform. So these kinds of interpretive scales or categories that are evolved for a particular scale increases its value rather significantly. And so we can see here is essentially some of the data paragraph for the LEM, and I think the scale's here. So this was what was developed for the LEM, and so this can be administered in the waiting room or while you're doing some other kind of activity, charting or something. And essentially, whatever their score is, here's the kind of categories we can place them in on the LEM. So basically, lower than 55 means that they're going to have difficulty with just ADLs. 55 to 65 is they have moderate difficulty with, they're able to walk up and down stairs and outside, use public transportation. Okay, but 75 to, above 65, it means now they're kind of walking up and down stairs with very little difficulty. They can kneel, Neil's still hard, but they can do it, and they can shop, so they're now at a participation level activity. And then 85 or above is unrestricted. Okay, so this knowledge of what the actual categories are, scores, it gives a lot of meaning and utility to the measurements. So when we find this on a measurement, it's very good and usually useful. So here's a case example where you have a 68-year-old hip fracture patient. You've seen them 8 times in home care. These are their outcome assessments. How effective was your treatment? So essentially we have hip flexion manual muscle testing. It went up by 1.5 grades. We improved them 8 seconds on the tug, and on the LEM they've gone from 55 to 65. And so the tug scores dropped into a lower category, and certainly the LEM has changed from just problems with basic ADLs into moderate difficulties. And so by knowing, first of all, documenting that they've changed, we can justify the treatment that we did do, and the fact that they're continuing to improve may be a further justification to continue treatment until they reach a higher functional level on the LEM. Here's another example of a very popular scale, the AUS-West 3 Disability Scale, and we can notice here that it comes in these different categories. And so when we see these categories, they immediately become useful to us. So interpretation is becoming more common and something that we find really desirable. So we haven't covered MCID yet, but we've covered the idea of how a construct gets developed, and it's obviously not straightforward or black and white. That it takes time and usually more than one study to establish an instrument's validity. And usually there's one study that initially comes out and it's very positive. For example, the LEM's comparison to the Harris Hip score is rather obvious that it's a better scale. And then it gets validated that it's converging on the right concepts and it's diverging on other concepts, and then it measures known groups, and so then we're like, okay, this is measuring the idea or abstract concept that we want it to in terms of tracking progress and self-reported function in elderly people. And so we would do the same thing with scales and kinesiophobia or disability or what have you. Okay, thank you.